So in 1998, there were 6 categories of Ehlers-Danlos syndrome: the classical hypermobility type, the vascular type, kyphoscoliotic type, and so on. Arthrochalasia and dermatosparaxis were the most rare of those. And we now know the molecular etiology of 5 of those 6 disorders. We still do not have a molecular cause for what was caused the hypermobility type and what we're now calling the hypermobile type. So from the time of Ghent since the Villefranche nosology, there have been meetings, international meetings in Ghent, in Paris. There was another one in Glasgow in 2015. And it was at that time that Laura Bloom and Shane Robinson committed the resources of EDS UK and the Ehlers-Danlos National Foundation to the development of an international consortium. That led to the meeting in New York in 2016, at which the new nosology was proposed. And the results of that meeting were published in a journal, in the American Journal of Medical Genetics, in March of this year, 2017. We anticipate the next meeting will be in Ghent in 2018 to revisit the new nosology, the new diagnostic criteria, and to decide whether mid-course corrections are necessary. So that May 2016 symposium had the goals of building a revised nosology or classification that defines the diagnostic criteria, to define new Ehlers-Danlos syndrome types as needed, and then to begin the process by which management and care guidelines are being developed for each EDS subtype. There were 4 committees for the 3 major types of Ehlers-Danlos syndrome and, the rarer types. And the chairs of those committees formed a steering committee for the symposium. And then there were working groups for each of the recognized comorbidities, and this is a list of the working groups and the chairs of those groups. So as a result of all that work, there were 18 papers published in the American Journal of Medical Genetics in March 2017. And you can see, there we go. So this is the Ehlers-Danlos Society website, and there is a link here to the 2017 EDS classification. All 18 papers are available free of charge at this time through the Ehlers-Danlos Society website. So I believe the journal has given us 6 months from the date of publication to make them freely available. So if you click on that link, you get to this page, which gives you the, all of the PDFs from all of these papers. So the classification of Ehlers-Danlos types in 2017 is listed here. There are 13 types recognized now, and we still have only one for which the molecular cause is unknown. That's still the hypermobile type, and it's still the most common of the 13 types. And as you heard from Dr. Castori, there was a recognition with the new diagnostic criteria that we really needed another way of thinking about patients who have joint hypermobility but do not meet the diagnostic criteria for any of the types of Ehlers-Danlos syndrome. And so Dr. Castori and his committee came up with this spectrum of joint hypermobility, which he explained very well in his presentation. And we now have a large range of names to give to people who have hypermobility, either symptomatic or asymptomatic, and running the gamut from completely asymptomatic through to those people who do meet the diagnostic criteria for hypermobile Ehlers-Danlos syndrome. So I'm just going to run very quickly through the diagnostic criteria for the classical, vascular, and hypermobile types of Ehlers-Danlos syndrome. I'm moving more quickly than I would like in the interest of time, but we will have some time for questions at the end, and I would like to refer you to those classification papers as a means of providing more information. So the major criteria for the classical type of Ehlers-Danlos syndrome are skin hyperextensibility and atrophic scarring and joint hypermobility. And you heard from Dr. Graham about the skin issues in Ehlers-Danlos syndrome. He's really given you a lot more information about that than I have time to do right now. But the stretchiness, the degree of involvement of the skin is what really sets the classical type of Ehlers-Danlos syndrome apart from all the others. And this extreme degree of hypermobility that you see here in this gentleman, and the extreme degree of scarring, which is typical on this is not projecting very well, but because of the skin fragility that we see in the classical type of Ehlers-Danlos syndrome, when toddlers are walking around and they're just learning to walk, they walk into the coffee table, the skin splits. And so you get typical scarring on the shins that's absolutely typical of the classical type of Ehlers-Danlos syndrome. And you saw about the Beighton score from Dr. Graham and from Dr. Castori. This is a 9-point scale that we use. And the minor diagnostic criteria for the classical type of Ehlers-Danlos syndrome are this list: easy bruising, soft, doughy skin, the skin fragility or traumatic splitting that I mentioned. There are molluscoid pseudotumors, which kind of feel like a little bit like a rubbery egg underneath the skin, and subcutaneous spheroids, which are much more rigid, almost feel like little calcifications underneath the skin. You may have a history of hernia or observe hernia on examination. Epicanthal folds are seen in some people. And then there are the complications of joint hypermobility, including sprains, subluxations, and chronic pain. Or a family history of a first-degree relative who meets the clinical criteria. So to make the diagnosis of the classical type of Ehlers-Danlos syndrome, according to the 2017 criteria, you need to have the major criteria number 1, which is the skin hyperextensibility and atrophic scarring, and then either the second major criteria, which is generalized joint hypermobility, or 3 of the 8 minor criteria. And the committee recommended that there be verification of the clinical diagnosis wherever possible. We know that molecular analysis of the type 5 collagen genes, these are COL5A1 and COL5A2, will identify a causal mutation in more than 90% of patients and should be used as the confirmatory test. In Europe, electron microscopy is used much more widely than we do here in the States. And there is a typical appearance of cauliflower fibrils of the collagen fibers when you look under electron microscopy. So that's another option if you have it available. The absence of these molecular confirmation does not necessarily exclude the diagnosis. There are about 10% of patients who really look like classical EDS who do not have a type 5 collagen mutation identified. But it should make you think about other possible diagnoses if you're not able to confirm it with the molecular testing. Now, the vascular type of Ehlers-Danlos syndrome has the following major criteria: a family history of vascular EDS with a documented causative variant in the type 3 collagen gene. Type 3 is the type of collagen that underlies vascular Ehlers-Danlos syndrome. These patients may have arterial rupture at a young age, and typically these are the arteries, the medium-sized arteries in the abdominal cavity, so the hepatic artery, the renal artery, the splenic artery, so on. they may experience spontaneous rupture of the sigmoid colon in the absence of known diverticular disease or other bowel pathology, and they may experience uterine rupture in the 3rd trimester of pregnancy. Carotid cavernous sinus fistula is also a possible complication of this condition. And there's a long list of minor criteria. I will not go through all of these at this time because of the time constraints. But the committee suggested that there are minimal criteria suggestive of vascular EDS, and these include the family history of the disorder, arterial rupture or dissection at under 40 years of age, unexplained sigmoid colon rupture, or spontaneous pneumothorax. And what they said was that in the presence of other features consistent with vascular EDS, any of these 4 minimal criteria should lead to the diagnostic studies to determine if that person has vascular Ehlers-Danlos syndrome. And testing for vascular EDS should also be considered in the presence of a combination of the minor criteria that the committee listed. But the diagnosis of vascular Ehlers-Danlos syndrome rests on the identification of a variant in one allele of COL3A1 that is deemed to be pathogenic. Just a little aside here, we have had a kind of a sea change in the way we describe molecular variants over the last, I would say, 2 to 3 years. We're not really talking about mutations anymore. We're talking about variants that are rated by the molecular laboratories as being pathogenic, likely pathogenic, variants of unknown significance, likely benign or benign. So we're looking for pathogenic variants in COL3A1, which would be a disease-causing alteration in the type 3 collagen gene. Now, as Dr. Castori explained, the new criteria for diagnosis of hypermobile Ehlers-Danlos syndrome were designed to emphasize the syndromic nature of this condition. We wanted to reduce the clinical heterogeneity of the group of people that are labeled with this diagnosis and to facilitate research into the underlying causes. And we really do expect that further clinical experience and research will lead to a revision of these criteria with time. We're in the process of assessing how well do these criteria really help us in identifying affected persons. Now, one of the issues was that those 1997 criteria for hypermobile type EDS were these. There were 2 major criteria, the skin involvement and generalized joint hypermobility, and 3 minor criteria, recurrent joint dislocations and chronic joint limb pain, or positive family history. But the only guidance that we were given by this 1998 paper in terms of using these criteria was that the presence of one or both of the major criteria was necessary for clinical diagnosis. So you could have a person with generalized joint hypermobility but without the skin involvement, or vice versa, and that person might be diagnosed with the hypermobility type of Ehlers-Danlos syndrome. So the criteria were neither very specific nor extremely sensitive. And we found that many people were being both underdiagnosed and overdiagnosed. So the criteria were not serving anybody very well. Now, the 2017 diagnostic criteria now require 3 different criteria, and the clinical diagnosis of hypermobile EDS it's much more complicated than it used to be. So we're in for a little bit of a ride here. Hold on to your seats. So the first criteria is generalized joint hypermobility, and the suggestion is that we use the Beighton score. There's a whole committee on this international consortium that's looking at the Beighton score, recognizing, as Dr. Graham said, that the Beighton score does not completely capture the whole picture of joint hypermobility. But the committee felt at the time that the paper was written between 2016 and 2017 that there really wasn't enough data out there to support expansion of the Beighton criteria. So that's something that may be coming in the future, but for right now we're still using the Beighton score. It's a 9-point scale. But the change is now that for prepubertal children and adolescents, the cutoff for generalized joint hypermobility is the number 6. So for children and adolescents, a score of greater than or equal to 6 is required to say that the person has generalized joint hypermobility. For men and women post-puberty up to age 50, we're using a cutoff of 5. And for men and women older than 50, a cutoff of 4. Now, the committee also recognized that this 5-point questionnaire that Dr. Graham and Dr. Castori mentioned can be used to kind of supplement the observations of the Beighton score. So if the Beighton score is 1 point below the cutoff for age, and the 5-point questionnaire has at least 2 positive answers, you can make a diagnosis of generalized joint hypermobility. And this is the 5-point questionnaire. Can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And then finally, simply, do you consider yourself to be double jointed? So again, if we have 2 affirmative answers to these 5 questions, and the Beighton score is 1 point below the cutoff, we can make the diagnosis of generalized joint hypermobility. Now, criteria 2 for this diagnostic set of criteria for hypermobile EDS requires the presence of 2 or more of the following features. And the committee divided them up into A, B, and C. And so you can have A and B, B and C, or A and C positive. And feature A speaks to what Dr. Castori was saying in terms of the systemic manifestations of a more generalized connective tissue disorder. There's a long list of these systemic manifestations, and the cutoff was set at 5. So 5 of these systemic manifestations, excuse me. So I'll read through them. Unusually soft or velvety skin, mild skin hyperextensibility, unexplained striae without a history of significant weight change, bilateral piezogenic papules on the heel. The piezogenic papules are little bumps that we see when people stand on their heels. They put their whole weight on their feet. They're little bumps that poke out. It's the subcutaneous fat poking through the connective tissue underneath the skin. Recurrent or multiple abdominal hernias like umbilical, inguinal, or crural hernias, and atrophic scarring involving at least 2 sites without the formation of those scars that I showed you that are typical of the classical type of Ehlers-Danlos syndrome. And then we may see pelvic floor, rectal, and or uterine prolapse. The committee chose to exclude people who've had, women who've had children from this criteria. So that particular feature cannot be used in women who've had children already. Dental crowding and a higher narrow palate. Arachnodactyly, those spider fingers that are typical of the marfanoid habitus, and that is as defined by either the positive wrist sign, which means that you can take your little finger and your thumb and wrap it around your wrist and it will overlap by the full distal phalanx. Or the positive thumb sign, you put your thumb across your palm, close your fingers across them, and the thumb actually sticks out by that full distal phalanx. So that's what we mean by the thumb and wrist signs. The arm span to height ratio is another feature of the Marfanoid habitus, an unusually long arm span related to the height, and the presence of mitral valve prolapse, mild or greater based on strict echocardiographic criteria, and dilation of the aortic root. So 5 or more of the items listed on these 2 slides are required to make a positive, a plus sign for feature A. Oh, where's the rest of my slides here? I seem to have lost features B and C. B is the positive family history. So that would mean that we have to have a person who meets these diagnostic criteria independently, and then the musculoskeletal complications include chronic pain in 2 or more limbs for more than or equal to 3 months, or chronic generalized pain for more than or equal to 3 months, or recurrent joint dislocations. So A and B, B and C, or A and C allow us to make the diagnosis for criteria 2. And then the last criteria, criteria 3, is really a matter of exclusion. We want to make sure that none of the other hereditary disorders of connective tissue apply in the case of the person to whom we're evaluating. So I don't know what happened to these last slides, but I really recommend that you go to the Ehlers-Danlos Society website and take a look at the paper describing the nosology. There's a lot of really good information in there. And as we continue to gather information about the utility of these criteria, I'm sure they will be evolving with time, and that Ehlers-Danlos Society website is going to be a really good place to look for continuing information. As Dr. Castori mentioned, it's very important for all of the subspecialties that are looking at these patients with their various comorbidities to think about Ehlers-Danlos syndrome as a possible explanation. These patients present with so many complex medical issues. And Heidi Collins, who was the chairman of the medical advisory board for the Ehlers-Danlos Society for many years, loved to say, when you can't connect the issues, think connective tissues. So thanks very much to ASAP and Dr. Bolognese and Dr. Kula for the invitation, to the support of the Ehlers-Danlos Society and EDS UK, and to all my patients and their families. And thank you for your attention.